I had such a unique patient case to share with you. In fact, it's so unique that my residents and I are doing a full case write-up on it. I'm curious at which point you'll know what the diagnosis is. Leave a comment down below if you figure out before me. Let's get started. Beep-whoop. A 45-year-old gentleman presents for a one-day history of a 101 fever, that's Fahrenheit, and no other symptoms. He's evaluated by another member of my staff, is found to feel well otherwise, have no other symptoms. The doctor that was seeing him diagnosed him with likely a viral illness, unclear which one because it was so early in the course. We did a swab for COVID and flu, both which were negative. Explained that likely in the next few days, symptoms would evolve and we would have a better understanding of what's going on. So he was instructed to come back if symptoms were to worsen, change, or be prolonged. 2 days later, same patient comes back and sees me. Now the patient has a 3-day history of a fever with a Tmax, that's a temperature high, of 103.5 degrees Fahrenheit, which is quite a significant fever. Whenever a patient has a fever, you start wondering what is causing their immune system to react by raising the basal temperature of the body. Usually the body does this in reaction to an infection, bacterial, viral, in more rare cases, fungal. But really what you're trying to evaluate in one of these patients is to figure out where is the source of this infection? Because if it's viral, it's more likely to be across a variety of body parts. If it's bacterial, it's usually centered to one organ or one body system. So you start asking questions, which I did. Do you have any respiratory symptoms? Stuffy nose, sore throat, cough? No. Interesting. Not an upper respiratory or even lower respiratory infection. So then we start thinking, okay, perhaps there's a gastrointestinal component to this. Do you have any upset stomach, abdominal pain, diarrhea, constipation, blood in your stool, nausea, vomiting? No. I even started thinking about rashes, asking the patient if they have rashes. No. Now, I've had cases before with patients where they said they have no rashes, and then we do a physical exam and we find rashes, but in fact, they're a high school gym teacher, so they taught a health class and knew to check for rashes and were so confident they didn't have one. The review of systems was coming up blank on seemingly everything. So then we start exploring other possibilities. Let's go to the urinary system. Do you have any frequency, hesitancy, burning on urination? No. Do you have any symptoms with your genital area? Are you having any discharge, any rashes, any unique issues where you're feeling discomfort down there? No. We can't forget the neurologic system. I ask about headache, visual changes. I'm trying to think, is there a meningitis component here? Rare, but could be. No. In fact, the patient says they only feel bad when they have the fever, and when they take fever-lowering medication, they feel perfectly fine. So now we know, no travel history, no risk factors, feels well outside of the fever. This has never happened to him before, otherwise healthy, takes no medications, and yet has this fever. I've seen stuff like this happen before, and usually it ends up being some kind of weird viral scenario, like an atypical presentation of mono or EBV. In fact, I tell my patient that I suspect it's that. Even then, when I do the physical exam, I feel no lymph nodes, no posterior cervical chain adenopathy. Man, this situation just keeps getting more and more frustrating because this is becoming one of these rare diagnoses called FUO. Fever of unknown or unexplained origin, where all you have is a fever without a clear explanation for why you have the fever. You have to do an FUO workup. Now, this is an invasive workup in the sense that you have to order a lot of lab work, blood work. You have to get CAT scans of multiple parts of the body, thereby radiating the body. So I don't love doing that in patients who are otherwise comfortable and are physically able to withstand having a fever for a few days. I feel like it's much easier to order some lab work, see if we get some information, also see how the symptoms evolve in the patient, and then make the diagnosis or make a change to the diagnostic plan and get the CT scans then, because that always remains an option. But you have to make sure your patient is on board with that plan. My patient happened to be on board with that plan. So I said, we're gonna order this lab work. I'll call you back in a couple of days and we'll decide a treatment plan. Order the lab work. initial results come in. Inflammatory markers, CRP, ESR, ferritin, elevated. CBC, all over the place. Multiple things off, no clear pattern, white counts a little bit down, platelets a little bit down, lymphocytes a little bit up. Still possibility that this is a viral picture, but we don't have the viral results yet. Later that day, we get the results. Just as I expected. Mononucleosis, positive. EBV, somewhat positive. And I asked the patient, he swore that he had mono in the past. So this is interesting because when I ordered these EBV titers, the way that you are able to analyze them to understand what you're looking at is based on a few factors. So you have EBV, IgM, EBV, IgG. Now, if the IgM is positive and the IgG is negative, odds are you have an acute first-time infection of mononucleosis. If on the flip side, your IgM is negative and your IgG is positive, that likely means in the past you've had mono, overcame it, and now have immunity to it, which most people have because mono is a pretty common condition. But then there's a third option, IgM negative, IgG positive, and then early antigen IgG positive, signaling that the person was infected with EBV in the past, fought it off, developed immunity, but now has reactivation of the illness. Just like shingles is a reactivation of chickenpox, which is caused by varicella zoster. It's the same infection. So I said, great, we have an answer. My patient has mono reactivation. That is why this is happening. I call the patient, I tell him the good news. He's very grateful, very happy. And he says, what should be my expectation here, doc? And I explained that it's very likely he'll have a fever for the next 5 days or so. And then it should just, the fever curve should go down and down and down, meaning that the highest temperature of the day should be lower and lower each following day. And I said, if that does not go according to plan, please let me know. 5 days goes by, I hear from the patient. He says, doc, you were right. I don't have a fever anymore. Tomorrow I'm going back to work. I'm ready to hustle and bustle. No issues. Thank you for making a great diagnosis. I feel so much better, no fever, etc. I'm great. And I'm like, wow, okay, that worked out totally. I'm still telling you the story because it's about to get more complicated. 5 days after, on a Friday, early evening, patient reaches out, and I specify Friday early evening because it's a really crappy time to hear from a patient that something's not going well because you have very few options of how you can help them outside of sending them to an ER. So it kind of handcuffs you into what you can do to help your patient out. I hear from my patient, and he says, doc, bad news. Fever's back since yesterday. What do you think I should do? I said, well, how high is your fever? And he says, oh yeah, 103. I'm like, what? We had full resolution of symptoms, a window of you feeling normal, and now again, you're feeling terrible. Nothing makes sense. Luckily for me, I was working on Saturday the next day in the morning with my residents. Patient comes in, vitals normal, looks comfortable, no changes to physical exam, no new symptoms, no new history added. My residents tried to ask questions and we're all at a loss. So I called my ER friend, Dr. Donald Pettit, who you've seen on the channel. And luckily for me, he was driving with another ER doctor in his car and he put me on speakerphone and I was able to present this case to ask for a curbside consult from 2 established ER doctors. They heard the case. They're all equally as confused as me. They started thinking really outside the box and saying, he's having a fever. Odds are he has an infection. Why don't you just treat him with Doxy? And I said, well, look, I see what you're saying, but I tested him for Lyme. Lyme was negative. This isn't a true fever of unknown origin because I have a positive mono test. It's just an atypical mono presentation. Maybe it's that. I thank them for their help and I decide against the Doxy for 2 reasons. Reason 1, my patient is comfortable. My patient has normal vital signs. He can withstand a fever. Second, this isn't a true fever of unknown origin. I know he has mono, I know he has EBV due to these blood tests, so I'm still going off of that diagnosis. And I decide not to treat with Doxy. Instead, we decide to broaden the blood work. Check for more rare conditions. Really chase those zebras as if I am House MD reincarnated. I order a tick-borne panel. I order CMV. I order autoimmune tests that I haven't ordered in a long time. I said, look, we're gonna send all of these tests and simultaneously get you in with an infectious disease doctor early in the week. Patient is on board. We have a good line of communication. I say, we're gonna do this. We send out the blood tests. Right away, we get our answer. Patient has anaplasmosis. Anaplasmosis is an infection that is spread by the very same tick that spreads Lyme disease. It's just a different bacteria. And I'm so glad we checked, because if anaplasmosis goes untreated early on, it can become quite problematic. But because we caught it, right away, I sent my patient a prescription for doxycycline, which is exactly what Dr. Donald Pettit told me to do. The patient was very grateful. The next day, he had his appointment with the infectious disease doctor. They confirmed that this is the treatment. In fact, I think I ordered doxy for 10 days. The infectious disease doctor extended it to 2 weeks. Just a few days of antibiotics. Patient's fevers go away. 2 weeks later, get all his lab work back. All pristine, all good, no issues. Liver enzymes down, inflammatory markers down. CBC is completely normal. There's also an important takeaway here. Tick spread illnesses are on the rise in the US. Why? Summers are hotter, are longer, springs are earlier, winters are milder, so there's less tick die-off, so ticks are more present and are spreading more readily. Part of this is due to climate change because of this weather cycle that we're experiencing. There's also obviously differences based on how often people get this diagnosed, how much we're looking for it, deer and mouse population, all these vectors that we have to think about. But it's important that when you're in a tick disease endemic area, like I practice in the Northeast, you think about these diseases right away because they're very easy to miss. And in a situation like this, if we were to miss them, there could have been true harm done to the patient. If you enjoy hearing about my patient encounters, click here to check out one where I saved my patient's life against her will. Click here to check that out. And as always, stay happy and healthy.